All right. So again, welcome to everybody to this month's meeting. Just some Zoom features. We've all been, I know, Zooming for the past 2 years straight, but we do use our the chat function quite often. It's right there in your options at the bottom of your screen. If you want to private message someone, you are more than welcome to. You just click on their name and you can private message them. If you do need live transcript, that is available. You can just click the little CC down at the bottom and it'll bring the live transcript up. And then if you do want to participate in our participatory sections, feel free to raise your hand. That is in the reactions section down in your options. All right. Now this is since we are partnering with Comagine Health for the Patient Family Partnership Hub. Their mission is together with our partners, we work to improve health and create a better health care system so that people and communities will flourish. And our mission and vision and values here at PFCC Partners. Our mission is to center the inclusive human experience of health, reinvent through radical collaboration, be a catalyst for system transformation. We reach our mission through our values of equity, inclusion, diversity, collaboration, and solution focused. Our vision at PFCC Partners is a health system transformed, one that works with people and through communities as a partner in their well-being. This is our Patient Family Partnership Hub structure here. We have our overall PFA network, and this is more of a focused partnership hub where we engage people from existing PFACs in the Comagine Health states. We provide you all with engagement opportunities, PFCC events, community events, and skills development, which we will actually be talking about a little bit later. All right, so this is our agenda. Don't know what happened there. This is our agenda for today. We'll start off with Katie, who will give us an update on Comagine Health staff structure. Lindsay will lead our intervention logic models discussion, and we will give you some updates on some engagement opportunities. So we'll start off with our welcome. Let us know your name, where you're located, and what is your favorite summer activity? I know summer's almost over, but what is your favorite summer activity? So I'll go first. My name is Laura Jackson. I am the Community Director for PFCC Partners, and I am located in Eugene, Oregon, where we are having the oddest heat wave ever. So my favorite activity is getting in the water, whether it's the beach, we have the Willamette River here, just being near water. So I will go ahead and pass it off to the next person on my list is Jan.
Okay. I'm just figuring this out. Okay, so it looks like I'm unmuted. Jan Lambert in Salt Lake City, Utah. And I too love the water, but you probably know that Utah does not have a lot of water. And talk about hot summers. I mean, we've had more days, we've matched the record for days over 100 for one summer. And so if we have one more day over 100, we'll break the all-time record for the number of days over 100.
Wow.
So it's, yes, very hot here. But I love to be outside, especially in the morning and the evening when it's not so hot. So walking, playing tennis, just anything. I even love to garden. I just love to be outside in the summer because we have very cold, yucky winters, and I don't love those.
Yep. I understand that for sure. Thank you. Chris.
Hi.
Oh, which
Oh,
Chris?
there's two Chris's. I see Chris Morgan on my screen. Go ahead, Chris Morgan.
Hi, I'm Chris Morgan. I'm from Hayden, Idaho. My favorite activities are walking, hiking, and biking, and being around water, trying to stay out of the smoke from all the wildfires up here. And we've had a wacky summer too. Cold all the way up until the first day of June, and just like they predicted, 75. The rest of the time we're all in the 60s as everybody else is burning up everywhere else. So,
Oh my gosh.
so nothing's growing, nothing is, gardens are all bad. Fruit trees aren't producing,
Oh, no.
it is what it is.
Yeah. We had rain all the way up until June, and then it just was 100 degrees. Just
Exactly, right?
Thank you. Thanks for joining us.
Thank you.
Now, Chris Syverson, you can go.
Hi, my name is Chris Severson. I am in Reno, Nevada. And my two favorite summer activities are camping and gardening.
Oh, nice. Thank you. Janice?
Hi, I'm not sure if you can see me. I have this phone and it acts funny, but anyway, I'm from Seattle, Washington, and I am a patient partner engaged with the University of Washington as well as Kaiser and healthcare for the homeless here locally. And speaking of weather, we had 7 days of over 90-degree weather, which is the first time that ever has happened in Seattle since recorded days. So we're all suffering, but today we have a little bit, teeny bit of rain, but the Navy, I wrote, the Blue Angels are here, so it's very loud, and I'm having to cancel, a talk tomorrow I'm giving because I'm worried they fly over. I can't get away from the noise. So anyway, but it's wonderful. And my favorite summer activity is staying in Washington State and Seattle because it is cooler here than most places. Thank you.
Thank you. Thanks for joining us. Dorothy.
Hi, I'm Dee. I live in Gig Harbor, Washington. And yeah, we did have a couple of 90-degree days, but it's about 69 today. I spend every day that I can on the beach with my dog. She loves to fetch in the ocean, and it's only about 8 miles from here, so we spend a lot of time there. That's my thing to do in the summer.
Nice. Thank you. Ashley?
Hi, I'm Ashley. I live in Vegas, and I wish we only had 90-degree weather in the summer right now. Although it has been an actual monsoon season the last week and a half. So it has been rather refreshing to only be 99 and 100 versus 117. So, but yeah, summer, what do we do in the summer here? We don't go outside. That's what we do. We sit in the air conditioning and run our electricity bill up. But my favorite obviously is probably sitting by my pool with an adult beverage and hanging out with my kids. So
That sounds like a great activity. Lindsay.
Hi everyone, I'm Melinda Galley. I'm located in Sacramento, California. So I feel like I don't have it as bad as Ashley, but it's still gets pretty dang hot here in the summer, and I feel like that's just spreading to all of you, so apologies. So my favorite summer activity, probably taking morning walks, because that's the coolest time of day, and then being near any body of water the rest of the time.
Thank you. Yeah, Lindsay and I always swap weathers. Thank
Yeah,
you.
it's nice down here and it was 100 up there.
Yeah.
It's hot
Back
now.
and forth. Yeah. And Katie.
Hi everyone, it's Katie Frazier. Today, I'm located in Portland, Oregon, and my favorite summer activity is camping.
Nice. Thank you. I might have to get some camping places from you up here. think we're going to start becoming camping people. We'll see. All right. Did I miss anybody? Check. I don't think so. All right. Well, thank you everybody for joining us today. These are our Partnership Hub meeting agreements. I'll just go through them real quick. We have make the meeting a priority. Meetings will open 10 minutes prior to start. If you're more than welcome to join us to just kind of hang out or talk or connect or whatever you'd like to do. I will provide a rough estimate of how long we spend on each agenda item ahead of the meeting. That should have gone out in the agenda. I'll also provide context and discussion questions prior to the meeting. We do use a parking lot to table agenda items. So if we think of anything during the meeting, we can put it in the parking lot and either talk about it over email or forums or in the next meeting. In a group discussion, participants will use the Zoom raise hand function that I showed you earlier if they'd like to contribute to the discussion. Meetings are recorded and summaries will be shared after the meeting. If any concern comes up during the meeting, please private chat a Comagine Health or PFCC Partners team member. Oops. All right, actually, and we will go ahead and I'll pass it off to Katie.
Thank you, Laura. So our last hub meeting, we got a request from the advisors to understand a little bit more about the staff structure in the system-wide quality improvement division. So while this visual you're seeing here doesn't break down to all the staff levels, I just wanted to help clarify on where we're focusing right now while we look at those logic models. So up at the top, the VP of System-Wide Quality Improvement is Kate Elliott. And then if you direct your attention over to the black text, there's the Director of Population Health, Kate Drummond, and then Manager of Population Health, London Maynard Peterson. Those are the two people who are managing the projects focused on the logic models that we've been sharing. There are a number of people within those teams. Unfortunately, we don't have those teams filled yet as we're still doing hiring position within those teams, but there are a number of people participating on those projects. The other people you see listed in the opioid lead, Dave Cook, patient safety,
Katie, you're cutting out
which was for
quite a bit.
I don't know.
Should maybe move into a different spot. I'll give you a second.
Yeah, I'm in the car, so it might be. Is this better?
Yes.
Okay. I don't know where it dropped off.
You said
So
in the
basically
white.
okay, in the white are other leaders of SQI that have different interventions that they're focusing on, but in the black right now is where the logic models live.
Thanks, Katie. And I think this came from, so on the last Partnership Hub meeting, we started a conversation about the logic models, but because we had to reschedule that meeting, I think it fell on a different time that a lot of people weren't available. And so one of the patient family advisors wanted to know more about the teams that, or, you know, how the teams that are working on these improvement logic models were made up. So this is kind of the makeup of them. Unfortunately, like Katie said, we don't know exactly the positions that are on these teams, but we'll provide you more information as these teams are developed and that they hire more people to work on these teams. So if you can't see them. And again, we sent out the logic models for these areas. So there's the chronic kidney disease team, community hospital utilization, diabetes, COVID immunizations, influenza immunizations, and pneumonia and immunization. So all three of the immunizations there. So again, I think we can provide more information as these teams are built, but we wanted to bring this to you and bring the conversation back about these logic models and where all of you as patient family advisors see yourselves contributing to the work that is proposed for each of these teams. So we can bring those ideas back to the teams and then kind of move from there and start to integrate all of you, your experiences and perspectives into this important work that's going on. Any questions about kind of the staff structure? Janice, I see your question. And Katie, I don't know if you can see the chat. This is the staff structure and then logic models in each box. So this is the staff structure. And so under the Director of Population Health in the black text there, those teams are the logic model teams.
Okay,
So Katie, yeah, so Katie said, yes, the manager of the logic models is listed and associated with each of the logic models presented.
got it. Thank you.
No, it's good to have this clarification. So any other questions in looking at this? Is it helpful?
So opioids is like its own, and substance use is its own, right? Like director of population has three, the manager of population health had three, but opioid and substance use are separate each.
That's what it looks like, yeah.
Yeah, those teams have been working on their initiatives, and we've brought a few of them in previously. So their initiatives aren't specifically called out on this slide.
Okay, thank you.
But still vital to the work of Comagine Health. And yeah, I think, you know, as we move forward, there'll be more opportunities to partner there as well. Yeah,
I
Jan.
attended
Go ahead,
I attended a local substance use Comagine focus group, I guess you call it. There was like 40 people on the line, maybe 30,
Wow.
40, I don't know. Yeah, one evening, but some people from all different walks of life.
That's great. Local
yeah.
to Washington State.
I think Seattle area specifically. It's
Seattle.
one organization, so I knew about it because I'm on the listserv of an organization, and which is around trauma-informed care and harm reduction, which is kind of specific to that area if you know of substance use or opioid. So because I've been involved with healthcare for the homeless, I'm involved with a lot of different areas, right? Social determinant health areas. Anyway, it was interesting. So they asked us a bunch of questions, and I think it lasted an hour and a half, about a month ago. Yeah. Thank you. I wanted to know more about what they were doing. So yeah.
Gotcha. Yeah, thank you for sharing that. And I know you shared it on the forum as well. So appreciate you spreading that opportunity. Jan, you had your hand up.
Well, my question is, does each of these teams have members from across all of the states?
That's a good question, Katie.
Because I recognize some of the names and I know they're from Utah, but I don't know if they have members of their team from each state. So is the work that we're trying to do going to be across all states, I guess?
Yeah, so these logic model interventions are across all 6 of the Comagine Health Queen QIO states. We might not have staff on each of the projects in every state. We're just, we're not that big, but there are members in each state that are on different projects. So they are located differently, but they're working together across.
Yeah, Janice.
I should have clarified that it was a local organization. I'm not sure if I made that clear. So
Oh, it wasn't Comagine Health. Got it.
It was Comagine Health, yes, but they've been going to different groups in our greater Seattle area that work with individuals with substance use disorder or families or community of the people. So I think I noticed a couple of them that I knew. And
Mhm.
so I saw the direct invite, but when I saw where else they've had, anyway, it's a small world in that area. So
Yeah.
I know the organizations, but it was Comagine Health. Yes, interviewing our local people about experiences of family or personal use in this area.
That's great. And I would keep that in mind as we kind of move forward with our discussion, because so it sounds like the team working on substance use prevention and treatment is doing some local work, getting into the local communities, hearing perspectives and experiences to help inform the work that they're doing. So that may be a strategy that we can help these other teams move forward with. So if there isn't any more questions about this, I think maybe we can move on to the logic model discussion, because I would love to hear more of these ideas.
I have one more comment really
Oh
quick.
yeah, go ahead.
So the only takeaway was there was a few people on there with lived experience,
Mhm.
and they were very concerned they didn't receive a stipend. They didn't understand it before. It's like they would always let you know ahead of time. And so
Right.
they really felt strongly that individuals of lived experience should receive some sort of stipend. So I just want to
Yeah.
say that wasn't taken well. That was the only thing that was an issue, really.
Right.
Mhm.
That's definitely something to take away or bring to any other teams that might be hosting local focus groups as well. So that's good to hear. Not good to hear, but helpful to understand. So Laura, if you could go to the next slide. I wanted to just walk through one of the logic model examples that were shared, I think, after the last meeting. We shared out all of the logic models, and I know it was a lot of information and didn't expect you to dive into each and every one of them. If you did, great. But really just wanted to share them in an effort to, start to get some ideas, because as Katie had shared, these teams are still forming and are looking for ways to engage the Patient Family Partnership Hub and people with lived experiences into their work. So that is our task right now, is to really help these teams think creatively how they can interact with the partnership hub and provide other additional activities or strategies that they can do to engage patients and families, because at the end of the day, the work that they're doing will be influencing the community and people and patients and family caregivers. So I just wanted to quickly walk through an example and then open it up for discussion. I just pulled the diabetes program logic model to walk through really quickly, and then we'll chat about it. So the diabetes program goal is to decrease the percent of Medicare beneficiaries with poorly controlled diabetes or missing A1C values within a specific measurement year. And this might look a little bit familiar. We had somebody else come from the hospital utilization team, and they walked through their logic model as well. So might look a little bit familiar, but this is the goal. And so on the next slide, forgot what I put next. Okay. These are their proposed activities for each of those goals. So decreasing the number of missing HbA1cs. So their activities include outreaching to clinics in each of the states with the highest rates of missing A1cs, developing educational materials on patient identification and documentation, determine and address gaps and barriers to identifying patients, coaching clinic staff, developing and disseminating education materials on patient outreach campaigns, so to help those clinics outreach to patients, determine gaps and barriers in patient outreach and scheduling appointments, look at other additional educational needs, gather resources, and disseminate other educational, and educate via different modalities. So hosting webinars, using a listserv, direct mail, etc. And then they also have a pharmacy, why can I say that? Pharmacy pilot that they have proposed. So enrolling 7 pharmacies within a pilot, and more focused on data collection. So on the next slide, these are their outcomes. So our discussion is going to be how can we as patient family partners work with this team and the other intervention teams to make sure that they're reaching their outcomes and that their activities, encompass patient family engagement as well. So outcomes are to increase knowledge of patient identification, increase knowledge of patient outreach processes, increase access to diabetes management resources, and interventions led by pharmacy staff for patients with diabetes that are being performed and documented. In the long term, they want to decrease the number of missing A1Cs, improve patient understanding of the importance of A1C labs and diabetes management, pilot a workflow for patient identification and outreach, and demonstration of pharmacy staff in team-based diabetes management. So those are the outcomes. And on the next slide is their proposed impact. So impact, improvement in population diabetes management for targeted communities, better patient self-management and involvement in their diabetes care, gain better understanding of barriers and gaps to diabetes management to inform future initiatives and interventions, and recognition of pharmacy staff in team-based care that translates to ability to bill for diabetes management. And then they have some assumptions. And again, this is just an example that I have walked through, but looking back on the staff structure, there are 5 other teams, I think, that have similar logic models like this that we sent out. So the next slide will get into a discussion. And I believe, Chris, you were on the meeting last time with Linda, and we talked about this quickly. So just wanted to open the door for other ideas. And I hope your dog's okay with the thunderstorms. I know mine freaks out.
I don't know. Could you tell he's like shaking?
Poor baby. All good. Yeah, stay safe. So in having a slight understanding of these logic models, we wanted to gather what are ways that we can help contribute to the work that they have, that these teams will be doing, and what are some of those activities that can help those teams get to the impact and the outcomes that they're looking to see. So just like I described for the diabetes program, along with all of the other programs, are there standardized activities that each of these teams could be moving forward with when it comes to patient family engagement? So I'll leave it there. How do you think we can help these teams? Did you have something to add, Janice? Yes, I mute.
Oh, I did. I didn't mean to. I was going to type it, but I didn't want to be the only one talking. I've worked on, this is a UDS measure, Universal Data System, whatever. It's part of CMS collects for like primary care. And I know for sure for primary care, it's a HRSA, they're HRSA. And so anyway, we worked on this with healthcare for the homeless, which is, you can imagine, is very challenging trying to, acquire these. So the reality is some people have uncontrollable diabetes. I don't know how many of you know much about diabetes, and so over 9 is considered uncontrollable. And we do measure it to find out the population health. So I think one of the main things is being able to get out information that's effective, that are patient-facing materials. And really, I've learned a lot about what can go in offices and can't in recent months and some projects I'm on. So something like a card that would be very easy, something small, even a 3x5, but that just makes, because it shares a few of the benefits of it. And, time for a medication change, something like that, try to exercise and eat better. But I just want to say the reality behind all this is the social determinants of health. And I know that QINs, want to have, everybody's trying to have improvement. CMS wants to see improvement in this area. That's what all of these are about, are improvement. So the reality is, if you live in, like all of us were talking about the weather at the beginning, all over the US, we're having a lot of problems with food right now. Everything's expensive. And usually the free food that's given out, which is very, very beneficial, it is food, is mostly white bread and canned food, right? So when we're talking about A1C, it's a very real issue. It's also cheaper to get Burger King special for $5 than buy, chicken and salad. That's the reality. So yeah, anyway, I just want to say that's some of the barriers. So you can even be creative with something like that, right? Like put a picture of a burger and then, I don't know, hope for a couple vegetables or something, a little bit of a salad, even if it's iceberg. People think you're crazy, but it might be all people can afford. But anyway, and then just materials that focus on and the benefits of it, because I think it's hard for people. I mean, if all the, they have leg sores, can lead to amputation. Uncontrollable diabetes controls to heart disease, can run into heart disease, amputate. It goes on and on, right? So blood pressure is it can be a cascade event, but some people have it and manage just fine. So that's a lot, but sorry.
Yeah. No, I appreciate that, Janice. Thank you. Chris?
Yeah, diabetes is one of the main things that take your kidneys out, uncontrolled diabetes and blood pressure. But I think the more important part is what's the FDA doing to correct all the stuff they're putting in our food that's causing this problem. Not trying to control the problem, but what, the big picture all about.
Right. Yeah, absolutely. Benefits. Thank you.
Thank you.
And Katie put a good question in there, because I think for the logic models too, there is a lot of patient-facing materials that will be developed. So just through our discussion today, what would it look like to meaningfully engage all of you, other patient family advisors, to develop patient-facing materials? Because I know sometimes it can be frustrating when, a document that's already done gets brought to you and they're like, what do you think? But it's already done. What do we have the power to change? There's a lot of questions that comes with it. So also curious, what would it look like to meaningfully engage all of you in patient-facing materials and mix those together? And Jan, I saw your hand up before I asked that question. So if you had a thought, go ahead.
Well, no, it's, as Janice said, it's education, educating patients in each one of those logics. What it gets down to, I think, is trying to educate patients. They don't need to go back to the emergency room. They should, so it's all education. And if we can be involved, even though we may not be diabetic or have those certain problems, I think we can, just as normal citizens, be helpful in developing those materials to make sure we can understand them. So I think Janice is on the right track. It's education, and we can be involved in developing those educational materials.
So being involved in the development, not just as a reviewer of material.
I was going to say, be involved from the beginning.
Yeah, co-designing.
Co-designing. Yeah, and maybe because I like the focus group idea too, to gain a larger perspective of, sorry, I've got a gnat problem and it's very frustrating. Having focus groups to gain a larger perspective from, you know, a larger audience. So maybe encouraging them to, you know, host some stipend focus groups and helping them utilize what they hear from those focus groups from people with lived experiences to design educational materials. It's something we actually did in LA County at the beginning of COVID. We they were creating their frequently asked questions page about COVID-19, and they were like, we can assume the questions that patients and the community has, but let's ask what questions they have so we can help fill in the gaps. So kind of going through that co-design process, having a listening session, listening to what are your biggest questions about COVID right now and bringing those back, and then providing the actual, you know, needed information to the community that they were looking for. So all about co-design. I like it. And Ashley, I know that you have been part of the hospital utilization collaborative, right? In Nevada, is that what you're part of?
Well, I was actually going to email about that. I was on the first meeting and then I haven't heard anything since, so I don't know if I am or not.
Okay.
So, I mean, I would love to be.
Yeah.
I was only able to sit in on that first meeting. I had to leave a few minutes early, but I haven't had any follow-up. So I would love to be, if so, yeah, that would be great. So I can't provide too much insight because the first meeting that I sat in was very much just an introductory, who's here. There was a little bit of discussion around, I think, a very broad topic of like, how do we, you know, educate again patients on, you know, helping them understand urgent care versus emergency care. And, you know, I definitely missed a key meeting last week when I was on vacation regarding the logic models piece. So I think I have some content knowledge gap in being able to probably adequately and hopefully or effectively answer this question in terms of, you know, contribution. I 100% agree with the education piece. I think I always just go back to, and some of this is shaped by the work I do on a daily basis, to, you know, but how do we get to the patient to educate them, right? So absolutely, design beautiful flyers, very simple, very easy to digest, very quick, you know, pieces. But I also agree with a lot of what Janice is saying, and I think what we all know is, but how do we get that information to the patient, right? And when a patient can't get to the doctor because of so many other obstacles and barriers, how do we ensure that they still know, okay, these are the other resources that you can utilize, or these are people you can call, these are these types of things. So yeah, that's kind of my thought process, is what I was sitting here thinking about. So
I totally get that, and happy to help reconnect you on the hospital utilization. That's
thank you, appreciate
it. And it might be too, because I believe this was at our last meeting too, but you'll notice that Eileen isn't here. She has taken another position within Comagine Health, so she won't be directly involved with the Patient Family Partnership Hub moving forward, but she's still a big proponent for patient family engagement, and will continue to be within Comagine Health. We do have Katie, and they are looking to hire someone, I forget the title of that position, but under kind of more health equity, who will be taking over some more responsibilities of, you know, making these connections for patient family engagement within Comagine Health. So that was another update. Health equity manager. Thank you, Katie. But Eileen's still around in Comagine Health, but she won't be on these meetings anymore. So that may have been a drop off, but happy to help reconnect you. All right. So kind of what I'm hearing is focusing on patient education, how to get to the actual patient. So once you have the education, how is it going to get to the people who need it most? I like what you said, Ashley, and, you know, developing a list of resources. So even if it's just, you know, this is where you can get support for whatever it might be, things like that. But getting to the patients is a big one. Anything?
And I think
Oh,
those
go ahead.
resources need to be disease specific. So you're talking
Yeah.
about diabetes, those resources are different
Mhm.
and you would access them differently than if you had the heart rehab or
Yeah.
one of the other things we talked about.
Disease specific. Got it. Great. Well, Janice.
I thought I had my hand up. I want to say that since we're looking at 6 states, it's hard to give the resources other than like the national ones because we're dealing with 6 states. So it's a template. That's usually what they have been doing. But
Okay.
rather than a flyer, I would highly recommend a card because that size and people might keep it. I don't know, even like a little business card with information, just I don't think a lot of people are aware that they're that it should be on, below 9.
Yeah.
So I served on the American College of Physicians guidelines panel for the measurement of A1C a few years ago. And the current evidence showed under 8. And there's a lot of pushback because really you want your A1C smaller, but that is that. But this is a measure that will always, it's better because there's a lot of people that have a little bit higher health-wise. It could be under 8, but that was what the current evidence showed. It's still going. It's still considered the best. But like 6.5 is really considered best. But we don't check it at that because we don't measure that because the issue is once it gets over 9, as other people have said, it's about kidney disease. So it's kind of like I think you want a little bit of stuff that's a little bit eye-opening. And then basic education and encouragement, but if it has to be, like a larger card or something, but to get it to them, social media, number 1. That's what I'd say.
Social media, yeah. And that might not be something that the teams are thinking about. I don't know, I'm assuming, but the use of social media, I agree, I think can be a great way to spread information. So that's, I'm taking notes and I'm gonna pull it all together. And then once these teams are developed, we can start to share some of these ideas. And I think it is a good opportunity because these teams are in the process of being formed to be able to get in there soon or, kind of put in their ear, like, hey, we are here. We want to help you design whatever patient education materials or patient facing materials that you'll be working on. We want to be a part of that design process. So that is good. Anything outside of the patient facing materials, and maybe if you want, you could take a little bit more time to look at the logic models again, and something might come up for you, new ideas, but definitely got the patient facing materials piece. Just curious if any other ideas had come up. Ashley?
Sorry, I was processing my thought, which is why it took me a second.
That's okay.
I think some of this too, again, I know missing last meeting wasn't the best thing in the world, but when I think about just this broad question of like, how can you contribute? I guess my answer probably is going to be depending on what it is that I'm involved with and what their goals are and what they want to do, and what logic model they're using, right? So I think that's where I'm struggling in formulating an answer that I feel like would be worth even spitting out, right? Because I think so much of it really is, well, if I'm on a team that wants to talk about hospital utilization, then sure, my lived experience is everything that happened in the hospital. If I'm on a team that wants to, improve blood clot support groups, absolutely, I'm there in a minute. But if I'm on a kidney disease, there's probably only so much that I'm going to be able to, contribute in terms of reviewing patient education models, because kidney
Right.
disease is not, fortunately, my area of expertise. So I think a lot of it will just kind of, I really go back to those like advisor portfolio, or what am I calling it? Profiles, there it is. That we
Yeah.
did at the beginning of the year, and really figuring out like, how do they want to utilize us, right? And how can our experience within, I mean, we have a vast majority of experiences, but compared to what it is that they're looking for, may really shape that contribution answer in terms of,
Yeah.
you know, how I feel like I could be helpful. Well, it kind of depends on what's the project, what are their goals, what, you know, and then I'll help from wherever from there. But yeah, I think that's why I'm just struggling a little bit maybe with trying to find an effective answer. So I apologize.
No, don't need to apologize. And that's really helpful. It's what I'm hearing is it's not a one size fits all. Like we can't say or we can help the teams in this way. We can help each and every team by doing this. It's going to be more of getting into each individual logic model, understanding their goals, and then figuring out from there, you know, where they see the patient family advisor fitting in or supporting their efforts, and vice versa, where we as patient family advisors see ourselves fitting in as well. And I think, you know, for the diabetes program, it's really focused on educating patients about that, which is why I think that's kind of where we focused right now. So I'm going to take that back. And I think it just as, I believe his name was Aaron, came to talk about the hospital utilization model or the collaboratives that they're moving forward with. Hopefully, as these teams develop, we can have kind of managers or team leads from each of these teams working on the logic models to come talk to us and then do a brainstorm to get more specific and focused. It sounds like that might be a better way to go, but I think we still got some good ideas from here. So I really appreciate that. Good stuff. All right. And Dorothy or Dee, just wanted to check in because we hadn't heard from you. Anything to add?
No, I guess what I'm sitting here, I'm just listening because I want to figure out. Well, I want to know what you want me to do, I guess is the better way to say it.
Okay.
Yeah, you assign me any little task that you want. You know, we have somebody up north and I'm in South Sound, and you know, I'm retired, so I have time on my hands, but
Okay.
you know, just guide me in what you want me to do. Okay.
That is also helpful to hear as well. We wanted to be inclusive and kind of involve everyone in deciding how we can contribute. So that's also really helpful. Thanks, Dee. And Chris M., I know this might be overwhelming. It's your first meeting, but anything else to add? Any questions? There's always more to learn, you know?
Yeah, I'm finding it interesting for the first meeting. You know,
Right.
I've got a friend of mine that in Coeur d'Alene, that pharmacist that volunteers his time to teach the homeless about diabetes on the weekend.
Wow.
And I also teach about kidney disease on, you know, I volunteered we work together actually to teach people about, you know, causes of kidney disease. So
Wow, great.
but
That's
that's
it's
sort
good
of
to
what
know.
we do. But you know, with you know, the medical situation the way it is, a shortage of people, and
Yeah.
you know, everything going on, it's hard to have that one-on-one interaction with folks. Whoever brought up the card idea, I think, is a good idea. Just
Mhm.
pack it full of information on the card and be able to get it out to the people, you know.
Yeah.
I'm
You can
curious
keep it in
on
your wallet.
I'm curious on the A1C thing. How often do they test that? Shouldn't that be a yearly thing for everybody? Or is this coming down to the insurance companies wanting to pay for stuff?
So the measure, according to HRSA, you can look up UDS measuring A1C under 9. It's one of their measures. I do know primary care has to collect it. I'm not sure if hospitals wouldn't have to. Anyway, it's like once a year. So, but
Okay.
also they want it this is population health. So say population health is your health system, right? It could be your one clinic, or it could be like Kaiser, right? So
Right.
you want a certain percentage of your population should have had this, and they have thresholds that they're supposed to meet for
Right.
CMS
Right.
organizations are. So anyway, they just want to have them improve. So that's why they're that's what iPro is helping to do, to have an improvement, just like they'll talk about kidney function, something you'd like to be involved with too, right? So
Right. And
yeah,
I wish they would check everybody's creatinine level every year too. That's a simple blood test.
or GFR.
Yeah, either one. I mean, it's, head the problem off before it gets started,
Right. Yeah.
So,
More preventative.
absolutely.
Yeah. No, and I think that's all really helpful. So the more, the more that we can help these teams help the people, the community, patients, families get ahead of some of these things, I think, or, be more preventative and looking forward, the more that we can help to improve these focuses. So I think these are great ideas, and I agree. I like the small card that you can get out there broadly, whether it's through pharmacists or your physicians, community-based organizations, wherever you can, to get this information out in an easy, small way. Just here's some information you need to know. Good stuff. So great ideas. Taking all this back, we'll continue to bring more information about these logic models more specifically moving forward, so we can dive into really, tangible ways that the teams see how we can partner with them and vice versa. So more information to come, but I really appreciate everyone participating in this discussion. I think I'll pass it back to Laura. Nope, I think I have one more thing.
Oh, yeah. Oh, well. I real quick, we did want to thank you all, those of you who gave us feedback on the chronic kidney disease flyer that was sent out a few weeks ago in an email. That team that asked for that feedback let me know that they are working on, they're taking in all of that feedback. We got a whole lot, which is great. So they're taking all of that in and redoing the flyer. And once they have that, they will send it back to me. So you all can see the hard work you put into giving feedback to this flyer. So thank you all for all of that. And we will be in touch very soon for that in the future. Okay, now you can, Lindsay.
And I was muted. So we are presenting again the core competencies of effective partners. So this is through our national network of patient family advisors, the PFA network, but open to all of you, of course. It's a great opportunity to continue to build your skills and learn from other patient family advisors across the country on how to effectively partner, collaborate with healthcare in more ways than one. And we're really excited about this particular session because we're offering it in both English and Spanish. So if you have friends, community members, anyone, everyone is welcome. I have the objectives here, but really just a great opportunity to get empowered, learn more about how you can use your lived experiences to partner with healthcare, just as we're doing here, and we'll continue to do a whole lot more of. So starts next week. It's 2 parts on August 10th and 17th from 1 to 2:30 p.m. Pacific time. Thank you, Laura, for putting the registration in there. Now I think I'm done.
Okay. All right, thank you. And that is all. We'll go ahead and wrap up. We have just a few minutes. If you have any general questions or anything like that, we'll stay on the line. Don't forget, we have our Comagine Health Hub forum. Feel free to post if you have any opportunities or any questions in between our meetings. to go ahead and post on the forum. I will post the recording of this meeting along with the discussion questions we went through. So if you think of anything else, feel free to comment on that post when I put that up as well. And I added the registration link for core competencies of effective partners in the chat. So we hope to see you all there next week. And if not, we'll see you all next month. Thanks for joining.
Thanks, everybody.
Thank you.
Appreciate your time.